minute or two for a few folks to join before we get started.
All right, it's 1 o'clock. We're going to kick things off here. Good afternoon, everyone, and welcome to the 5th episode of Ewings U. I'm Piero Spada, and I'm going to be your host again today. I'm also one of the co-founders of the Little Warrior Foundation and dad to 12-year-old little warrior Lucy. Today, we are thrilled to be hearing from Dr. Matteo Trucco. Dr. Trucco is currently the director for the Children's Cancer Innovative Therapy Program and clinical director for the pediatric hemonc and bone marrow transplant department at Cleveland Clinic Children's. He is also practicing pediatric oncologist at Cleveland Clinic Children's and Case Comprehensive Cancer Center, and associate professor at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University School of Medicine. Dr. Trucco completed his medical training at Temple University of Medicine in 2006, followed by his residency in pediatrics at Rainbow Babies and Children's Hospital in 2009, and fellowship in pediatric hemonc at Johns Hopkins Hospital and the NIH in 2012. It was during the fellowship that Dr. Trucco started researching sarcomas in the laboratory of Dr. David Loeb, some of whom you may have heard of. Specifically, he worked on developing techniques for identifying and targeting the sarcoma cells that are resistant to conventional therapy and are believed to give rise to metastases and relapses. Dr. Trucco continued his research in sarcoma resistance when he was recruited to Baylor College of Medicine and Texas Children's Hospital in the laboratory of Dr. Houston. He studied sarcoma cell metabolism as a target for overcoming chemotherapy resistance and began his work in developing clinical trials. In 2016, he moved to the University of Miami, where he participated in and developed several clinical trials aiming to overcome cancer resistance to chemotherapy and immunotherapy via the addition of metabolic inhibitors, tyrosine kinase inhibitors, ALDH inhibitors, and applying evolutionary principles to change how and when we administer chemotherapy to stay ahead of chemotherapy resistance. So suffice it to say, he has become a leading sarcoma expert. In addition, Dr. Trucco has become involved in several foundations focusing in on sarcomas. Dr. Trucco is also the co-chair of the National Pediatric Cancer Foundation Sunshine Project Consortium, a member of the advisory board for MIB Agents, Sebastian Strong, Clear Cell Sarcoma Foundation, and he also moderates the multi-institutional virtual tumor review board for osteosarcoma, otherwise known as TURBO, and the National Ewing Sarcoma Tumor Board, otherwise known as NEWS, and the focus of today's talk. When not working, Dr. Trucco enjoys spending time with his wife, Christine, and daughters, Paige and Claire, playing billiards, painting, and he recently picked up fly fishing. He considers it an honor to be invited to speak with patients and families about topics related to sarcomas and the efforts to develop better treatments for these terrible diseases. And right back at you, Dr. Trucco. Thank you for being here to talk about these topics. But before we kick things off with you, I just want to let everybody know and remind you all that Ewings U is a webinar and podcast production of the Little Warrior Foundation. We are a national childhood cancer foundation with a laser focus on finding a complete and permanent cure for Ewing sarcoma. We were founded in April of 2020, have granted out 1 million in high potential therapies for increasing survivorship and decreasing toxicity. We very much so rely on the support of the communities of big and little warriors who are joining us on this call and across the country. We are really appreciative of all of our community's support to continue our mission so that we can continue to bulldoze our way to a solution and continue this vital work. So with that, I'm going to send it Maggie's way to introduce herself, and we'll continue from there on.
Yeah, thanks so much. And thanks for everybody for joining us and Dr. Trucco for being here. Really excited to hear all about the NEWS Tumor Board today. Just a quick reminder of our format. Dr. Trucco will talk for about 30 minutes, upon which we'll switch over into question and answer. At the bottom of your toolbar, please use the Q&A feature. Emily and I will be moderating for questions and queuing those up for him when we get to the Q&A section. Emily?
I'm Emily McFadden, the third co-founder of Little Warrior Foundation. I just want everyone to know that this webinar will be recorded today and posted on our website. You can see previous episodes of Ewing's U there. We are always want to hear what you want to hear about in these. And as we plan our winter and spring curriculum for Ewing's U, we welcome any suggestions of topics or researchers you'd like to hear from. With that, I will kick it over to Dr. Trucco.
Thank you, everybody. Let me share my screen.
Looks good.
Yay. Okay. So thank you. It's an honor to be here and to be invited to speak about this project, which actually kind of fell on my lap, but we ran with it, and I think it's of value, and I hope the community thinks it's valuable. You'll notice this it says CTOS. We submitted an abstract to this conference, which is in November. It's the Connective Tissue Oncology Society. It's the big sarcoma international conference, yearly conference. And it just so happened to have a session on telemedicine and tumor boards. And we thought this would be perfect. And it was accepted for oral presentation. So since I just finished the slides, I figured it's you guys can see what the docs will see, and I added a little kind of example of what the tumor board looks like with one of the cases we presented, just so you guys get a sense of what we're looking at and what we discussed during those tumor boards. So this all started when members of the Carson Sarcoma Foundation approached one of my colleagues who's a radiation oncologist, and he has a lab and he studies evolutionary dynamics in cancers and something specifically called collateral sensitivity. That's where if I treat you with one drug, cancer with one drug, what does that do to the sensitivity of the tumor to other drugs? And can we take advantage of that to kind of plan out the sequence instead of kind of doing the same thing over and over again? But when they gave him that money, they also kind of had a stipulation that some of the funds would go towards making Ewing sarcoma expertise available to everyone. This patient had actually traveled from out of state to get some of his care up here. And so we assembled a team, basically our sarcoma team, which involves pediatric oncologists, adult oncologists, surgeons, radiation docs, interventional radiologists, pathologists, to kind of think about how we can do that. And the idea of a virtual tumor board came up, and then we used what little creativity we had to come up with news. But it actually turned out that as we were planning this out, money wasn't really an issue. None of the funds needed to support this because the virtual platform is something our institution has. We had some resources to kind of have the intake, and we volunteer a lot of our time, be it our coordinators or the docs that attend this tumor board. We fit it into our schedule. The goal was this. You can read it faster than I can. But basically, it was twofold. One is for patients being treated by docs who just don't have a huge amount of experience treating Ewing sarcoma because it is relatively rare. Give them a way to present to a group of people with more experience. But I've been specifically told by some of my colleagues that there's also value in experts talking about cases together. And then they wanted me not to minimize that, because there are some complicated cases where even if you've been doing this for 40 years, it's still good to get someone else's opinion. And we've certainly had some insight and some good ideas that have come up as part of the meeting. So it is a little bit twofold. We didn't want this to be the Matteo Ewings tumor board. We didn't want it to be the Cleveland Clinic Ewings tumor board. We wanted to make it the National Ewing Sarcoma Tumor Board. So we got our experts from our sarcoma team, but also a bunch of experts throughout the country. And, you know, tried to aim for kind of the not too young, not too old crowd, kind of the up and coming leaders in the field. And then a huge shout out to Patty, Heather, Amanda, and Matt, who kind of do the logistical stuff and a lot of the stuff behind the scenes to kind of make sure we were able to launch this tumor board and that it runs smoothly. So this is what we came up with, the National Ewing Sarcoma Tumor Board. It's monthly, it's virtual. I wanted it to be monthly because if you don't do it consistently, it's hard for people to kind of plan to attend. And we also thought that if it was, you know, quarterly, that's not going to help a patient who has Ewing sarcoma. On the flip side, if we did it more frequently, I'm not sure we'd have enough cases, and I didn't want to start canceling because we didn't have any cases to discuss. So monthly seemed to be a nice balance. The time that worked for most of us was the second Monday of the month from 5 to 6 p.m. Eastern Standard Time. We used WebEx because that's what our institution has available to us with IT support. Teams was the alternative. Nobody likes either of these, but WebEx seems to be the lesser of both the evils. We have a secure database called REDCap. It's mostly used for research, but we were able to use it to have a safe way for physicians to submit cases. And that's the link that the physician can use. Cases can only be submitted and presented by the medical team. We make it a point that the doctors need to kind of feel free to talk about the cases, and we also have to protect patients' privacy, and that's why only physicians are allowed on the meeting. It's submitted through the REDCap database. It comes to us. It's usually me that kind of reads over it real quick to make sure it is an appropriate question. You know, sometimes people submit cases that aren't actually Ewing sarcoma. Sometimes it's, let's say, there's really no question there. And sometimes, you know, those have been really the only problems that we've really run into. I also like to know what the questions that they're asking for input on are, because I can make sure the right specialists are there. If it's a question about lung surgery, make sure a lung surgeon's there. If it's a question about radiation, make sure a radiation doc's there. We send them a PowerPoint template just so that we have the presentations organized in a specific way. And then we specifically say, if you have a question about pathology, about the diagnosis, and you want to show the biopsy, there's no way for me to do it for another doc without them shipping slides to us. And that's just not feasible logistically. So they would have to bring their pathologist and share the slides. Similarly, if they want a radiologist to kind of go through the scan, they would have to do it on their end. They can't send me the scan and have it uploaded because we have to scrub them of patient medical information. And I mentioned if we need specific specialties, we make sure they're involved. Once the PowerPoint is kind of completed, we ask that they send it to us, one, in case they're having technical difficulties to share, two, so that we can do one final check to make sure that there's no protected health information on there. This is what the first sheet of the intake form looks like. This is what the first slide of the actual template looks like. And on meeting day, there's a brief welcome. We discuss 1 to 4 cases at a time. It's amazing how we can actually sometimes fill an entire hour just discussing one case. It's the submitting physician who presents the case along with what specific clinical questions they have. There's someone from Cleveland Clinic moderates. Usually it's me. Sometimes it's some of my colleagues also do. And then we have somebody scribe, just kind of take notes of what's discussed. Sometimes the moderator can be the scribe also, but usually it's a separate person. And then we actually return a summary of the discussion to the submitting physician within 24 to 48 hours of the tumor board. We also built in a couple surveys just to see kind of how useful it is, whether or not they've been able to, they found it useful and were able to change anything based on the discussion that was had. And we imagine in the future those surveys can be a little more informative, but for now, that's how we started. So this is a case that I presented. Sometimes we don't have a lot of cases, and so we actually just kind of pull in some tricky cases that we have dealt with over the years. I'm sorry if the formatting's a little off. And this is something that became one of the biggest sort of challenges, is our legal team had to approve things. And so they made sure we had disclaimers everywhere on the intake, on the template when you log into the WebEx, that this is just for educational purposes. We are not offering formal second opinions because we're not seeing the patient. Sometimes we're not even seeing the full scan. We're just seeing a representative image of the scan. But hopefully it can be of value, and if needed, a formal second opinion can be done subsequent to this. So this is a 13-year-old female, Saudi Arabia. This is kind of how the histories are presented kind of chronologically. Thigh pain, found to have a mass, biopsy showed it was Ewings, had a lot of lung mets at the time, was treated per the standard European approach with a good response, had surgery, got more chemo, and whole lung radiation. That's often the typical story we see because everyone gets treated pretty much the same up front. And then kind of the more pressing matter, in this case, she developed headache and was found to have a new mass on the back of her skull. They treated her with chemo, initially had a good response, but then her headaches came back and the mass started growing again. That's when they came to us. One other thing, she has a kidney that's out of place, and so it only has 13% function on that side. Most of it's her kidney functions on the other side. This is the original tumor. And again, unfortunately, in this format, it's hard to show scans and kind of scroll through them. So what most often we do is we take screen grabs and present them. So this is your typical X-ray. There's a fracture there, actually. And here's the MRI of it. This is that lesion that she had in the back of her skull, and this is showing that it grew. And this is what it looked like, again, before we started treating it. And here I did find a way to actually be able to scroll through a scan, except it's not the easiest. You gotta kind of try to stop it. But again, trying to get people a clear picture of what this looked like. And here is a beautiful reconstruction of the veins. You can see here that mass on the back of her skull. So up until when she came to us, she had only gotten radiation to her lungs. That's always important information. Here's what her leg looked like after the reconstruction, the limb salvage surgery. And then the questions for the group that day were, what's the best approach for local control for this skull mass that's actively growing on second-line therapy? Should we do surgery? Should we do radiation? Should we do surgery and radiation? Should the radiation be before the surgery or after the surgery? And what systemic therapy, that's your chemo, would you give, and would you give it with the radiation or not? And that's what the discussion was all about. Some people advocated for surgery, other people advocated for radiation. And there's pluses and minuses to both, and some people had experience dealing with a tumor in the same location. And oftentimes there's consensus. Sometimes there's disagreements. I would view them more as different options that could be taken, and all seemed reasonable. And again, oftentimes, we're just kind of confirming what people were going to do anyway. Other times, you really do get an idea or a thought that someone might not have thought of before. any questions about kind of that's what it looks like. These are some of the numbers from the first year, or a little more than the first year, because it started in July of 2021. You know, we've had 15 tumor boards, 34 cases discussed, so a little over 2 cases per meeting. 21 different centers, including one center in France that presented a case and then wanted to present a follow-up on that same case. And you can see, you know, you start off strong and then things dwindle a little bit, but I mean, for the most part, saying low 40s, high 30s is not inaccurate for what we get. I will say it's typically the same people join month to month. Some people don't join because it's not, it conflicts with their time, their clinic time or something like that. It's nice to have some similar recurrent faces and people that really seem invested in this attending. And sometimes you get new names joining. The discussions vary, but you know, they can focus on the choice and timing of local control. One thing I appreciate is people share what clinical trials they have available at their sites or they know are available out there. There's always a lot of discussion about choice of relapse therapy, role of maintenance therapy, and the management of subcutaneous Ewings, which is actually incredibly rare, actually has come up a lot because they have very good prognosis with standard of care, but it almost seems like it's overkill to give the full 14 cycles of VDCIE. So that's come up a couple times. These are the follow-up surveys. You know, they're very generic at this point. Just, was it informative? Do you think you'll change your treatment because of it? Would you present again? Any comments? And then 6 months later, again, was the discussion useful? And please provide some details. You know, we only got 9 responses back. Was it informative? Most people say yes. One person said no. One person wasn't sure. You know, and this is the kind of comments we get. You know, it's nice to know that it was challenging for everybody. I think it provided more family ease to know the plan was discussed with other centers. And I think if at the very least we can provide that, I think that's a win. Second question, do you think you will change your treatment plan? Most people say no, and I'm not surprised, because one of the challenges we had is, how do you reach out to people that are not in the sarcoma community? You know, I know who the sarcoma people are, so I can invite them, but I don't know about someone in the middle of nowhere, rural hospital who may need to reach out. So that's why it's great that Little Warriors and foundations like them are sharing information that this tumor board exists to share with their doctors in case they want to bounce the treatment off of some experts. And again, not really going to change my treatment, but provide support both for the physician and the family, I think. Would you present again? No one said no. And some other comments, some were very nice, others, you know, are what they are, and that's okay. It's always challenging to get the right people on there at the right time, but we do our best. And again, hopefully that summary we sent them is useful to share with anybody else that's not able to attend the meeting. 6-month follow-up, was it useful? No one said no. Most said yes. And, you know, again, the general theme is, it was, even if it's just support, validation, that seems to be of value. And, you know, it's funny during these discussions, sometimes you kind of spin it into, well, shouldn't we have a clinical trial looking at that, or shouldn't we do a study looking at that? And that's actually what I hope also comes out of this, is we putting a bunch of experts in a room together. You hope they start working together a little bit more. And some info on how we could improve. And this was at the end of 1 year, and so we incorporated some of it, molecular data, making sure radiation and pathology were present. Getting international submissions. We might have to change the name of the tumor board if we do that. But again, what we're doing is we're kind of trying to spread information about the tumor board through kind of word of mouth, and everybody can share the invite and see if it spreads that way. We are presenting it at CTOS, which is international, and we'll have the information out to providers. Again, we might get inundated with international cases. The timing becomes a little bit difficult. That gentleman who presented from France, it was close to midnight when he presented, and unfortunately, there's no way around that unless you have multiple tumor boards. But like I said, what do we do with this? We certainly discuss challenging cases. It helps make colleagues aware of available trials, and then take advantage of the group's expertise. We're actually drafting right now a paper on some of the challenges with upfront management of Ewing sarcoma, to kind of summarize the expertise and opinions of this group, or a portion of this group. And that's just the first of multiple papers we kind of dreamt up as we were talking, figuring there's way too much information to put in one paper. So this one, we have a draft completed. Hopefully we'll get it submitted in the next month or so, and help kind of iron out or highlight some of the challenges in upfront therapy. Even though it's the same, there are some nuances to it. The challenges in doing this, the biggest hurdle was dealing with the lawyers. Again, making sure no one got sued for any of this. The email list and finding collaborators and contributors. I mean, basically, you got to build it from scratch. There's no central database of Ewing sarcoma experts. And so I just kind of went east to west coast, all the institutions I could think of, and who the sarcoma docs are at those places. And that number has continued to grow since then. Finding a day and time that worked. I think we found one that worked, not for everybody, but for a lot of people. Sharing the scans and pathology. Again, we do those screen grabs, which are not perfect, but I think they get the idea across of what we're dealing with. Making sure the right discipline is there. Every once in a while, there's a radiation question, and there's no radiation oncologist there. There's limited conversation at that point. And then getting enough cases. I was mentioning to folks before we started how, last month, the meeting coincided with one of our annual Children's Oncology Group meeting. And so we only had one case submitted. Over the summer, people were on vacation, so we didn't get a ton of cases submitted. So it's always a little bit of a challenge when we have the wherewithal of, ooh, we only have one case. We'll usually dig into our records and pull up some cases just to kind of have some discussion. Then the other thing is getting people to speak up. I've certainly been texted and called after the tumor board for someone who wanted to share their opinion. I'm like, why didn't you speak up during the meeting? And then there are some people that really like the sound of their own voice and seem to dominate the conversation, and trying to get them to, we appreciate what you have to say, but let's hear from some other people. So that's kind of the art of moderating. That has been a bit of a challenge. And then no good deed goes unpunished. Once people heard that we had a Ewing's tumor board, the osteosarcoma folk wanted a tumor board. So we launched that one too. That one, because it was in its infancy, only got a poster at CTOS, but that will also be discussed. And very similar platforms, some overlap in the people attending. But same concept. Let's get experts in osteosarcoma talking about cases. And that's it.
Great. Thank you so much, Dr. Trucco. That was super helpful. And it is just amazing to see what you guys have done in 1 year, and so heartening to see all of these physicians donating their time and their expertise. There's Dr. Pete Anderson in the background. Hi, Dr. Pete.
He's a big contributor.
We did get some questions through the chat, and also some anonymous questions submitted to Maggie and I directly. One person wrote that their son is 24 and has recurrent metastatic Ewings. As a parent, would it be appropriate to ask the doctor to present the son's case? This person's confident that they are getting great care, but want to make sure no stone is left unturned.
I mean, I think that's the ideal. That's what we want. I suspect that that oncologist probably doesn't even know this tumor board exists to present it. And you know, if you ask me, whenever a patient wants a second opinion, I say, let's see, one of two things could happen. One, they tell you, yeah, I would do exactly what Dr. Trucco says. And I'm like, yay, validation. Or they come up with something that I didn't think about. I was like, okay, great. You know, I love more minds thinking about this. So it would be totally appropriate, I think. You know, I don't know how that oncologist would act, but I suspect if you say, hey, I just heard about this thing, do you think you could present, you know, Johnny's case, and they can reach out to me, and we'll try to make it as easy as possible.
Right. You know, we see so many times in these recurrent cases, you know, you're trying something and you're white knuckle praying it will work, but you always want to have a plan of, well, what if this doesn't work or stops working? Kind of what is that? What's next? What's left for the options? And that seems like a perfect
And because of the 1 month schedule, I mean, it's rare that like I just got scans back and my patient relapsed. What do I do? It's usually more like, yeah, my patient's stable on this, but what will you guys suggest next? Or we just finished therapy, everything looks good, but I'm worried this is going to come back. Is there anything we should do in the meantime? You know, those are the kinds of questions that come up. So it helps to have a specific question other than am I doing everything right? But you know, we've also gotten questions like that. It is completely appropriate, I think.
I wanted to sorry, Meg, I know you have lots of questions too, but I wanted to piggyback on this one because this question came through, and this person is saying that they don't feel like they have a collaborative minded oncologist. And when they have suggested second opinions before, you know, it seems to have struck a nerve. Maybe this is outside of the tumor board discussion, but what advice do you have for someone who's working with a doctor who doesn't seem to want to work with others?
It's always challenging, for sure. And again, we certainly have a lot of egos in medicine and even in pediatric and adult oncology. I mean, hopefully something like this tumor board is a great way to kind of get that second opinion without, you know, feeling like you're going to lose the patient or something like that. Because, you know, we all have the burden of, well, you got to make your quota, and, you know, you got to bring in the revenue in the hospital, and losing patients is frowned upon. Again, I don't know if that's the motivation or anything like that, but hopefully something like this is a non-threatening way of, hey, pick the brains. I mean, John Healy, to get his opinion free of charge, you know, who wouldn't want that? You know, who wouldn't want Dr. Anderson's 2 cents on a case in a non-threatening, relatively relaxed environment? So, and you know, several other docs at the same time. And again, oftentimes people are just saying, yeah, you're absolutely right. I mean, that's exactly what I would do. And so it is validating. And I can imagine, the family feeling quite reassured if he's presented at a tumor board with 40 experts and they all say, yeah, you're doing exactly what I would do.
Great, thank you.
Awesome. I think on that note, one thing that I think as patients, we all recognize is how hard oncologists work and how crazy their schedules are. And so in line with that, one of the questions that came in here from Laura Rutledge, hi Laura, good to see your name in here, is just how do we make it easy for physicians? So if if this other than just, hey, email this Dr. Trucco, he's in Cleveland, Ohio, and he's got this thing that I heard about on a webinar, what are the ways we can make it as easy as possible, or any homework we can do in advance as patients to get the case? I mean, I know we can't submit it, but is there a link, a resource, a one-pager, a website?
Yeah, so there's that link, which I can share with you guys if you want to distribute it to the group, which is the intake form. And I mean, it needs to have full information, but I've done it, I've literally done it Monday morning when we were kind of needed a case and someone backed out.
Yeah.
It's not a huge time sink. And honestly, you can jump to the question at hand, we try to make it as easy as possible. So I think just having that link should be easy enough. And yeah, feel free to give them my email. And I will try to make it as easy as possible. Again, the template isn't terribly daunting, and it's a way to just organize it a little bit easier for them.
Okay. And then a second follow-up to that is for physicians who maybe can't make a scheduled time slot or are international and are just curious to be a fly on the wall, do you guys record sessions for, physicians to go back and listen to and learn from?
As of now, we have not been recording them just because, to a degree, we haven't necessarily thought about recording them.
Yeah.
Or had a place to put them, because then we need somewhere that, someone international could access it. I'm sure the lawyers would have a blast.
The lawyers will have something to say. Yeah.
Yeah. So as of now, we have not, but that's why we kind of provide the summary so that, the person that presented can then go to their team and say, this is what they said.
Okay. Before we jump to the next topic, I just wanted to mention on that, access, I think what we could do as a follow-up to this is for all attendees and anyone who registered and is listening to the recording later is tuck the link into our follow-up email so that everybody who is on this or listening to it can find that link and maybe share it with their oncologist or talk through it if it's something they're interested in.
Yeah.
Emily, did you want to take this next one?
Sure. And I'll add that there is a one sheet that we will distribute as well.
Okay.
I know because I helped make it. But this next question comes from Debbie. She is in the UK and her son is finishing frontline treatment. His tumor is being genetically sequenced, and saying, when the results come in from the sequencing, what can she do with that information in terms of any future treatment plan should he need it? So any recommendations you have for what to do with the information that comes out of genetic sequencing?
Yeah, unfortunately, most of the doctors are asking the same question. What do we do with this information? Because, we have that powerful tool of the genetic sequencing, and then what do we do with it? So, on the spectrum of genetic mutations in cancers, lung cancers and smokers is way over here. Ewings is way over here. So there's probably not going to be a ton of mutations in that Ewing sarcoma. Every once in a while there are, but usually you see the EWS-FLI1, maybe you see a STAG mutation, or there's a couple, and that's about it. It's a very quiet genome. It's that EWS-FLI1 that's really driving it. So there's a chance that there's just nothing there. There is the chance that maybe there's a mutation in the mTOR pathway. Well, we have drugs that target the mTOR pathway. Okay. So then as an oncologist, what do you do with that? Well, I'm not going to abandon VDCIE to put you on an mTOR inhibitor based on a genetic test where it's never been proven that in pediatric cancers that relying on a genetic mutation actually is better than using conventional chemotherapy. But where I, as a practicing oncologist, take that information is if I'm considering a clinical trial or a group of possible therapies in relapse, and one of them makes sense based on those mutations. This drug is this regimen includes an mTOR inhibitor, or, you know, again, there's several different pathways that can be mutated and inhibitors that hit those pathways. I might kind of, that trial suddenly goes a little bit higher on my list of things I'd be willing to consider because it makes a little bit of sense, but with the understanding that it makes sense intuitively, but it hasn't been proven to really work. And you know, what do you do when you're done with 14 cycles of VDCIE? Unfortunately, there we also don't know the answer. Unfortunately, you know, and that comes up on the tumor board a lot. We're done with VDCIE. I'm really concerned that this is going to come back. What do I do? Can I put them on something in the meantime? It's like, I mean, you can. Don't know if it works and don't know if it helps. Will the tumor come back anyway? Will it, if it doesn't come back, was it not going to come back in the first place? We don't have that answer yet. We are doing some trials trying to look at that specifically. And in fact, in that case, it's a little better for the whole community to do a treatment like that, we call maintenance, on a clinical trial so we can learn whether or not it actually helps versus I'm doing it on my own. If it works, great. It's my secret that it works, or that it worked, and I think it worked because we don't know for sure. If it didn't work, again, no one else knows that information, and so it's not terribly valuable to the whole community, even though it may or may not be valuable to the individual. So a little bit of a we don't know is the bottom line, but that's how I use genetic information. And we do, that case I presented didn't have it, but we do have a slide specifically for genetic information so that the whole group can then discuss, okay, what do we know? What do we think about how the genetics play into this case?
Great, thank you.
Out of curiosity, how many of the tumor boards, just roughly, would you say are for recurrent or refractory, and how many are approaching you guys during frontline?
Usually, I'd say about a third are frontline questions. Like it's in a bad location, a weird presentation. People thought it was something else, and then it turned out to be Ewings, and they already, like, you know, the surgery was already done. What do I do now?
Okay.
A third, I think, are in that the patient's okay now, but I'm worried something's going to happen. What can I do?
Mhm.
And another third is in relapse.
Okay.
You know, what other options are there?
Thank you for all of this. I have just kind of a open-ended question for you, which is, you know, as Piero was reading your bio, we're just so fortunate that there's doctors like you who like want to study this and who are studying this very challenging disease space. So I'm just curious to know, what are you excited about when it comes to Ewing sarcoma research?
What's recently really excited me is that, you know, back when I was a trainee and you know, writing grants, we started looking at this concept of not all the cells in the tumor are created equally. There are some that are resistant to therapy and they're just kind of hiding out. And those are the ones that lead to the relapses. And we called them cancer stem cells or sarcoma stem cells. And, you know, depending on the group we were talking to, some people flat out laughed at us. They're like, what are you talking about? You know, cancer is a cell that divides uncontrollably. There's no different cells in there, whatever. So, and that was 10 years ago to like, you know, not accept it, you're crazy, like, you know, to now I can't go to a talk, I can't like review a grant, I can't read a paper where they're not talking about subpopulations of cells. Not all tumors are created equally. Not all the cells in the tumor are created the same. And to see that shift and even how a clinical trial is designed, it used to be, well, you have to pick one drug at a time and you give it to 3 people, then you increase the dose, and you give it to 3 people and you increase the dose. To let's change how we're looking at this. Let's change how we're thinking about this. We got some projects where we're getting mathematicians involved in trying to model how the tumor is going to respond to various therapy. That first slide where I showed talking about collateral sensitivity in Ewing sarcoma. I mean, that wasn't even talked about 10 years ago. And it's just a brilliant concept how instead of just kind of hitting the cancer with the same thing over and over again, can we try to use our brains and be ahead of the tumor instead of trying to play catch up? Wouldn't it be great if instead of, you know, everybody keeping their fingers crossed when a scan comes, we actually are able to say, you're going to have, you know what's going to happen on that scan. You know, obviously better that we don't know that it's relapsing, but if we know this is around the time that you're going to relapse, we're ready to treat the patient with something else, and ideally know what to treat them with because it's probably sensitive based on what we had treated with them before. We're not there yet, but people are having these conversations, which they weren't having 10 years ago. And so, you know, whenever I run into a colleague who has these ideas, or, you know, you go to the big conference and there's all these posters and you come by one that's like talking about some of these ideas that are new or are different, that's what excites me. That's like, yes, because, oh my God, we've been doing this for 40 years. It's not working. Let's try something else.
Thank you.
Mhm.
Piero, I don't have any more questions on this end. Emily?
I got one last question that's a bit open-ended. It's obvious that you put a lot of elbow grease in setting up this program. What is the biggest surprise or outcome that you've had thus far in creating the National Ewing Sarcoma Tumor Board?
I've been very impressed with the consistency that people are on it, that big names, you know, Steve Dubois at Boston Children's. I mean, he's like Mr. Ewings. He's almost always there. I mean, that's awesome. Rick Rydell at Duke, he's an adult sarcoma specialist. He's there almost every time. We come up with the idea of, hey, why don't we use our combined superpowers to you know, write a paper, and a handful of people, like more than a handful, just jumped right in and were like, yes, please, let's write this. And as we were talking, we just kept coming up with more and more to write, where we were like, we can't fit this in one paper. That's a book, you know? So, you know, I've appreciated the enthusiasm of a lot of the community in doing it. The other thing that surprised me is how, you know, news is from an academic center is where it started, and kind of going out, and you guys caught wind of it, and you guys are hopefully going to help us spread the word. And, you know, Turbo was the opposite. It started with a foundation, and they kind of, yes, used an academic, you know, docs came on board. And news has the problem that a lot of the patient community doesn't know about it. But the docs know. Turbo has, the patient community knows about it, but the docs don't know. So we have like opposite problems, but hopefully both of them are going to continue to improve and get out to the people who can benefit the most from it.
Well, we'll certainly help spread the word for sure. I think with that's a good way to close things out here for us. Thank you so much, Dr. Trucco, for bringing this incredible initiative and resource to life. I know it wasn't easy. It obviously took a lot of grit and gumption to bring to life. And thank you for sharing your time with us. On a side note, I did love the acknowledgement of Chris Carson. And for the viewers that are on this call that don't know who Chris Carson is, he's very much a pioneer in the foundation space, the Ewing sarcoma space, and very much a leader. And hopefully we could only follow in his footsteps. And lastly, for the greater Ewing sarcoma community, thank you for making Ewing sarcoma research a priority in your lab. I know it's not always the easiest thing to study, but from the greater community, thank you for that. And in closing, thank you to our viewers, for all of us for joining us today. We will see you back here in November. Please be sure to subscribe to our Ewings U emails. You can do that by going to littlewarrior.org and navigating to Ewings U tab on the website. Follow us on Instagram and Facebook, as we always post about our next speaker that way as well. And lastly, in closing, Dr. Trucco, I don't know if you know how we sign off. We're going to sign off 1, 2, 3, swords up. So just give you a heads up there. We have a sign off here that embodies our fight and honor in memory of so many little and big warriors who have faced this cancer. So we sign off on all our communications, both internally and externally. And so while I know most of you are muted, those of you that aren't, that includes the 4 of us here. 1, 2, 3.
Swords up.
Swords up.
Thanks, everyone.
Thanks, everyone.
Thank you.
Thanks, Dr. Trucco.
Bye. Thanks.